Hello everyone, welcome to our Zoom meeting. Today we'll have different topics. I'm going to share the screen here. So this is the agenda items and Dr. Huzaifa will lead the Zoom meeting. Dr. Huzaifa, when you are ready, you can start the meeting. Thank you.
Yeah, okay. Good afternoon, everyone. I'm Dr. Huzaifa Ahmad. I will be serving as a moderator for today's Geriatric Research Fellowship meeting. Before we begin, I'd like to thank Dr. Nadir for giving me the opportunity to moderate today's session and for this continuous support and guidance to all fellow. And it is great to see all of you, our returning fellow and our new member joining us for this first time. As always, our goal is to share, update, learning from each other, and continuous advance our research and academic growth. So let's move on to our presenter today. Our presentation, our first speaker is Dr. Mawahib Mohammed, who will present on hematology. Dr. Mawahib, are you ready?
And before we start, the file, Dr. Mawahib, is it in the system, like the one that you are going to use? Is it in the app?
Yeah, it's the first one, hematology.
Yes, it is already present. It's already found in the application.
So I'm gonna just show the screen and tell me if I'm heading the right way. So here, so when I go down, this is the one. Do you see the screen?
Yes, this one.
This one, okay. Second, just
Assalamu alaikum, Dr. Nadir. Assalamu alaikum, everybody.
Alaikum assalam.
I can share it if you.
Okay, if you have it right away.
Yeah.
Go ahead. Yes, go ahead.
Okay, thank you so much.
Thank you.
Could you please just allow me to share it?
Yes.
Okay, thank you.
I'll try now.
Okay. Okay, do you see my screen?
Yes.
Yes, that's it. Thank you, Dr. Iman, for sharing.
You're welcome. I will mute myself. Just doctor, I wanna hide this like window. So.
Maybe if you want to disable sharing and then open the file in presenter mode.
Oh, okay.
And then you share that window for the presenter window. Share the screen again.
Oh, I still see it.
So
last time when I checked the YouTube, it's drawing the screen. I don't know. Okay, I just could leave it at the top. Do you think that's gonna be better?
Okay, you can keep it that way. Yeah, sure.
Thank you. You can go ahead, doctor.
Okay, thank you, Dr. Iman. So, hello everyone. My name is Mawahib Mohammed. Today I'll be presenting hematologic diseases and disorders. So, the objectives of this presentation are to know and understand how hematopoiesis changes with age, the classification and workup of anemia, the rational use of exogenous erythropoietin, the indications for vitamin B12 and folate replacement, in addition to know and understand how to identify and treat thrombocytopenia, thrombopathy, clotting factor deficiencies, and chronic myeloproliferative disorders. The topics covered are effect of aging on hematopoiesis, anemia, and different classes of anemia, B12, folate and homocysteine, platelets and coagulation, and finally chronic myeloproliferative disorders. So the next slide, please. The next slide, please. So the effects of aging on hematopoiesis. Well, hematopoiesis is the process of forming blood cells, the red blood cells, white blood cells, and platelets, which occurs in the bone marrow. The main effects of aging on hematopoiesis is that it diminishes reserve capacity. So as people age, their bone marrow becomes less active and contains more fat cells than stem cells. This means the body has a lower ability to increase blood cell production when needed, like after blood loss or infection. So older adults can't ramp up hematopoiesis as efficiently as younger adults. The second thing is that there is more variable response among older adults. In older adults, the hematopoietic systems respond less predictably to stress, like infection, bleeding, or medications. Some may respond adequately, while others show very poor recovery, hence more variable response. Also, hematologic abnormalities occur earlier and more severely under stress. So, under certain stress, anemia may develop quicker, and their immune cell response might be slower or weaker. For example, slower return to normal hemoglobin after phlebotomy, which is blood loss. Also, after donating or losing blood, older adults take longer to regenerate red blood cells and restore hemoglobin. Also, there is a reduced ability to mount a granulocyte response to infection. The next slide, please. However, there is no significant change in basal blood counts. So normal aging doesn't drastically lower blood cell counts in healthy older adults. However, there is a modest increase in anemia, especially in men. Older adults, mainly men, show slight rise in anemia, though not dramatic. There is no apparent effect in circulating EPO, erythropoietin, or HGF, the hematopoietic growth factors. So the levels of erythropoietin and hematopoietic growth factors in the blood don't change much just because of aging. There is a possible dysregulation of growth factor production. The production of these growth factors might become a bit less well regulated with age, but it's not clearly proven. There is a normal response to injected growth factors if no comorbidities. So healthy older adults respond normally to given erythropoietin or hematopoietic growth factors injections, so bone marrow can still produce cells if stimulated. The next slide, please. Now let's move on to the previous one. Yes, the incidence and prevalence of anemia. Well, anemia is a decrease in red blood cells or hemoglobin leading to reduced oxygen delivery to tissues. The main points that most common age-related hematologic abnormalities, the anemia is the most common age-related hematologic abnormality. Among all blood changes with age, anemia is the most frequent, with prevalence of 12 to 16% of women and 18 to 22% of men older than 80 years. So it's more common in men at advanced age. There are also higher rates in certain groups, such as hospitalized patients. It's also seen in geriatric clinics, patients who have multiple conditions, and institutionalized patients like those in nursing homes. In short, anemia is common in older adults, especially men over 80 and those who are ill or institutionalized. The next slide, please. The classification of anemia. It is either hyperproliferative anemia, it is either hyperproliferative or hemolytic anemia. It's either hyperproliferative, ineffective, or due to ineffective erythropoiesis or hemolytic anemia. So the hyperproliferative anemia means the bone marrow is not producing enough red blood cells, of course. The problem is with RBC production, not with blood loss or destruction like in hemolysis. So the reticulocyte count is low because the marrow isn't active enough. The causes of hyperproliferative anemia are the iron deficient erythropoiesis, as in iron deficiency anemia or anemia of chronic disease. So in iron deficiency anemia, it is caused by poor intake, chronic blood loss, or malabsorption. Without iron, hemoglobin synthesis decreases, so the RBCs become smaller and paler, and thus microcytic and hypochromic anemia. Anemia of chronic disease is due to chronic inflammation. So iron is present in the body, but trapped in storage and not released for RBC production. It is caused by infections, autoimmune diseases, cancers, and etc. In chronic inflammation or inflammation as a whole, increases hepcidin, which blocks the iron release. B is due to, the second cause is due to erythropoietin lack. Erythropoietin is a hormone made by the kidneys that stimulates the bone marrow to make RBCs. It is either in renal cause as in chronic kidney disease or endocrine cause, like hypothyroidism, for example, hypopituitarism, or adrenal insufficiency can decrease erythropoietin production or bone marrow. Also, as I mentioned, in chronic kidney disease, the damaged kidneys, in damaged kidneys, there is low erythropoietin production and low RBCs production, and thus anemia. The third class is due to stem cell dysfunction. So yes, stem cell dysfunction. The stem cells in the bone marrow are the mother cells that give the RBCs, white blood cells, and platelets. So if they are damaged, all blood cell lines may decrease, which causes aplastic anemia, in which there is bone marrow failure. There are many causes of aplastic anemia, like drugs, radiation, viruses, as well as autoimmune diseases, and it might be idiopathic as well. The next slide, please.
This is a hemolytic anemia.
Yeah.
Okay.
No, the previous one, please.
Yeah, thank you.
The ineffective erythropoiesis. So it might be caused also by ineffective erythropoiesis. So it is either macrocytic anemia. In this, it is either macrocytic anemia, microcytic anemia, or normocytic anemia, according to the size of the RBCs. In macrocytic anemia, there is defective DNA synthesis in the nucleus of the developing RBCs. The nucleus of developing RBCs matures slowly and thus become large or macrocytic. It is either caused by vitamin B12 deficiency, which is needed for DNA synthesis, folate deficiency, or myelodysplastic syndromes. Vitamin B12 deficiency is needed for DNA synthesis and causes megaloblastic anemia in addition to other neurological symptoms due to nerve damage. Folate deficiency folate is also needed for DNA synthesis, so it is similar blood findings as B12 deficiency, but there are no neurological symptoms. Myelodysplastic syndrome causes refractory anemia type, in which it's a bone marrow disorder with abnormal cell maturation and ineffective RBC production. It's common in elderly and can progress to leukemia. The microcytic anemias are either in this are either thalassemia or sideroblastic anemia. The thalassemia here, we are talking about the thalassemia trait, which causes the microcytic anemia, or seen as microcytic anemia. It is a genetic defect in globin chain production, alpha or beta. The marrow works very hard, but RBCs are abnormal and destroyed in the marrow. The second is the sideroblastic anemia, in which iron is available but can't be properly incorporated into hemoglobin, leads to ring sideroblast in the mitochondria in the marrow. The normocytic anemia, here we will talk about the myelodysplastic syndrome, can also cause normocytic anemia if the defect affects all cell lines equally. So the RBCs formed are morphologically normal sized but functionally defective. Okay, yes, hemolytic anemia. Now let's go for the hemolytic anemia. So hemolysis is the destruction of red blood cells. In this type, RBCs are produced normally, but they are destroyed too early, either in the bloodstream or the spleen. Normally, the RBCs live about 120 days, and in hemolytic anemia, they may live only a few days, 2 weeks. The causes of hemolytic anemia are, as we know that hemolysis can happen for many reasons. They are classified either to immunologic, intrinsic, or extrinsic causes. So the immunologic or autoimmune hemolytic anemia. The immune system attacks its own RBCs, destroying them. So it is subclassified into idiopathic or secondary. The idiopathic means that the cause is unknown. The body forms antibodies against RBCs without a clear trigger. For an example of this is the autoimmune hemolytic anemia, IgG type. The secondary occurs secondary to another disease or drug, like autoimmune diseases like lupus, lymphomas, or leukemias, and certain drugs like penicillin and methyl-dopa. Autoantibodies coat the RBCs and they are destroyed in the spleen or the liver. The intrinsic are either metabolic or due to abnormal hemoglobin. So the metabolic, there is defect in the enzymes that protect the RBCs from damage. For example, G6PD deficiency and pyruvate kinase deficiency. In abnormal hemoglobin, so hemoglobin structure itself is abnormal. For example, sickle cell disease and other unstable hemoglobin variants that participate and damage the cells. And finally, the extrinsic, there is an external factor. So RBCs are normal but destroyed by external factors, like mechanical hemolysis, physical destruction of RBCs while circulating. For example, prosthetic heart valves, shear stress breaks the RBCs, microangiopathic hemolytic anemia in conditions like DIC, TTP, HUS, in which RBCs get fragmented by fibrin strands, which leads to schistocytes, and which are the fragmented RBCs on the bloodstream. The next slide, please.
This next workup of anemia.
Workup of anemia. Practically speaking, hemoglobin is 12 gram per deciliter is the lower limit of normal for older men and women. In elderly patients, hemoglobin naturally tends to be a bit lower. However, 12 gram per deciliter is considered the practical cutoff. Below that, the patient is considered anemic. This threshold applies roughly to both older men and women. Clinical judgment is important to decide how aggressive to evaluate borderline low hemoglobin. If hemoglobin is slightly below the normal, not every patient needs an extensive workup right away. The doctors or the doctor should use clinical judgment considering symptoms, comorbidities, and general health to decide how much investigation is needed. Principles of evaluating anemia do not vary based on patient age. So the approach to finding the cause of anemia is the same for all adults, whether young or old. You still follow the same logical steps, classify by red cell size, microcytic, normocytic, macrocytic, and check iron studies, reticulocyte count, and etc. The first step is history, physical examination, and CBC. The next slide, please. Microcytosis is considered MCV less than 84, indicates impairment of hemoglobin synthesis. The MCV, mean corpuscular volume, measures the average size of the red blood cells. If MCV less than 84, the RBCs are microcytic. This usually means there is a problem making hemoglobin, the protein that carries oxygen, of course. Common causes of impaired hemoglobin synthesis include iron deficiency anemia, thalassemia, and anemia of chronic disease sometimes. The macrocytic or macrocytosis is MCV more than 100, may indicate reticulocytosis or abnormality in nuclear maturation. And red cell production is estimated from the reticulocyte production index, or RPI. The RPI shows how well the bone marrow is producing new red cells. It adjusts the raw reticulocyte count to account for the degree of anemia. If the RPI more than 3, then bone marrow is responding well, producing lots of new cells, seen in hemolysis or acute blood loss. When it is less than 2, the bone marrow response is inadequate, seen in bone marrow failure or deficiency states, as in iron, B12, or folate deficiency. The next slide, please. The first figure of workup. So, okay, in this figure, we check in case of macrocytic anemia, we need to check for B12 and serum RBC folate levels. This in macrocytic anemia. If the vitamin B12 is low, less than 150 picogram per ml, then this is a vitamin B12 deficiency, and treatment is with parenteral or oral vitamin B12. If the vitamin B12 is within normal, between 150 and 300 picogram per ml, and folate is 3 to 5, Then check for the MMA, the methylmalonic acid, and homocysteine levels. If the methylmalonic acid elevated, then again this is a B12 deficiency, and this patient needs oral or parenteral supplementation with B12. If the MMA and homocysteine are normal, obtain iron studies and ferritin. If results are normal, cause of anemia is considered to be unknown, and then consider bone marrow biopsy. If the homocysteine is elevated and the MMA is normal, then this is considered to be folate deficiency and treat with folic acid, 1 milligram per day. And finally, of course, if the folate level is low, less than 3 nanogram per ml, then this is a folate deficiency, of course, and the patient needs supplement with folic acid. This is the workup for microcytic anemia. First check for the serum iron, total iron binding capacity, iron saturation, and ferritin. If the iron is low and total iron binding capacity is within normal limits, and the saturation is low and ferritin is high, more than 100 nanogram per ml, then this is considered to be anemia of chronic disease. The main problem in anemia of chronic disease is that the acute phase reactants blocks the release of iron. So there is low, and ferritin is one of the acute phase reactants. So it is high, there is high ferritin, low iron. The ferritin may be high or it might be in a normal limit. However, it is not low. And the iron is low, of course. The total iron binding capacity is low, or it might be within normal limits. In this case, consider anemia of chronic kidney disease. If the iron is low, the second option is if the iron is low, total iron binding capacity is low or within normal limits, the saturation is low, and ferritin is between 16 and 100 nanogram. This might be iron deficiency anemia. Treat with ferrous sulfate, 325 milligram per deciliter per orally, and recheck reticulocyte count. There should be an increase in the reticulocyte count after 2 weeks. And if iron is low, total iron binding capacity is high, saturation is low, and ferritin is 15 nanogram or low, then of course this is an iron deficiency anemia, and treat with ferrous sulfate and recheck the reticulocyte count after 2 weeks. There should be an increase in the reticulocyte count after the management of the iron deficiency anemia. Okay. So regarding the first figure, the MMA is the methylmalonic acid is elevated in vitamin B12 deficiency because vitamin B12 deficiency acts as a cofactor for this enzyme, the for the enzyme methylmalonyl CoA mutase, which converts the methylmalonic acid methylmalonyl CoA into succinyl CoA. So when there is deficiency in B12, there is accumulation of this substance or the MMA. In addition to, as I mentioned earlier, in addition to the macrocytic anemia, there is also neurological symptoms that I will mention in the following slides. Okay. Hyperproliferative anemias. The first one is iron deficiency or iron deficient erythropoiesis. It is diagnosed by decreased serum iron and reduced transferrin saturation, which is calculated by the serum iron divided by total iron binding capacity. In younger people, the most common cause is absolute iron deficiency or blood loss, which leads to low serum ferritin and high total iron binding capacity. Because the liver is acting well, so it synthesizes transferrin very well in order to capture the iron. So the transferrin is high, the total ion binding capacity is high, and the ferritin is low. Also, the iron is low. In older adults, the most common causes are anemia of chronic disease and anemia associated with inflammation. The next slide. Iron deficient erythropoiesis, iron deficiency anemia, nutritional iron deficiency is rare in older adults. An unexplained iron deficiency in older adults is almost exclusively due to GI loss. The common causes are angiodysplasia of the large bowel, diverticular disease. So consider these two only after excluding the neoplasm. Blood loss anemia leads to low serum ferritin, high total ion binding capacity. The next slide. So in anemia of chronic disease, the laboratory features are mild anemia, low serum iron, low transferrin saturation, and normal to increased iron stores. The ferritin is more than 150 nanogram per ml. Because the ferritin is one of the acute phase reactants. So in iron deficiency anemia, I just want to explain this. In iron deficiency anemia, body iron stores are depleted. So serum iron and ferritin decrease, while the liver increases transferrin production, causing total ion binding capacity to rise. In anemia of chronic disease, inflammation increases hepcidin, trapping iron in storage and reducing its availability. This leads to low serum iron, but ferritin rises as an acute phase reactant, and total ion binding capacity falls because the liver makes less transferrin during inflammation. The next slide, exogenous EPO. It is used since 1985. It's been used for anemia due to end-stage renal disease, where kidneys can't make erythropoietin, and also for anemia in cancer patients receiving chemotherapy. If hemoglobin less than 10 gram per deciliter, treatment is generally started when hemoglobin drops below this level, below the 10 gram per deciliter, and the patient has symptoms. Monitor the hemoglobin weekly to avoid overcorrection. Too high hemoglobin increases the risk of thrombosis or hypertension. Add iron if ferritin less than 50 nanogram per ml, because erythropoietin increases RBC production. So if iron stores can deplete quickly, an iron supplement keeps erythropoiesis effective. The target hemoglobin is 10 to 12 gram per deciliter. This range corrects anemia safely without increasing cardiovascular risk. Stop if no reticulocyte response in 4 to 6 weeks. If the bone marrow doesn't respond, no increase in younger RBCs, erythropoietin therapy is ineffective and should be discontinued. In short, exogenous erythropoietin boosts RBCs production in certain anemias, but requires close hemoglobin and iron monitoring to ensure safety and effectiveness. The patients are given 1,000 microgram per 1,000 microgram daily of no, this is not here. Okay, the next slide, please. The hyperproliferative anemia is pancytopenia. So pancytopenia is a reduction in RBCs, white blood cells, and platelets. If it occurs without iron deficiency, it suggests the problem is in the bone marrow itself, not from the lack of raw materials like iron. The issue is more failure, so the bone marrow can't proliferate to produce normal blood cells. Common causes are drugs like chemotherapy, chloramphenicol, antithyroid drugs, immune destruction of stem cells, example, aplastic anemia, intrinsic Moro disease, myelodysplastic syndrome, Moro infiltration or replacement by malignant cells, as in leukemia, metastasis, or fibrosis like myelofibrosis. The diagnosis, a bone marrow aspiration and biopsy is essential to confirm the cause. It shows whether the marrow is hypocellular, infiltrated, or fibrotic. The next slide, please. The pure red cell aplasia as type of the hypoproliferative anemias. The pure red cell aplasia is isolated failure of erythropoiesis. The bone marrow stops making red blood cells, but white blood cells and platelets are normal. It's caused by some drugs, like some antibiotics and anti-epileptics, lymphocyte abnormalities, like autoimmune T cell suppression or association with thymoma or certain viral infections like parvirus 19. Generally speaking. So features, isolated anemia, only hemoglobin and RBCs are low. Serum iron is elevated because iron isn't being used for the RBC production. And also bone marrow exam, on bone marrow exam, no erythroid precursors, confirming the selective red blood cell aplasia. The next slide. Okay, macrocytic anemias as a class of ineffective erythropoiesis. The first one is pernicious anemia. In most cases, it's caused by atrophic gastritis leading to B12 malabsorption. Megaloblastic anemia. Signs include pancytopenia, macrocytosis, hypersegmented neutrophils in the peripheral smear, decreased reticulocyte index. Also, there is increased LDH and indirect hypobilirubinemia. This is because of hemolysis. Also, there is macrocytic anemias in older adults usually result from B12 and folate deficiency, but low B12 and low folate do not necessarily cause macrocytosis or anemia. Microcytic anemias. The first one is thalassemia, and here we're talking about the thalassemia trait. Occasionally detected in older adults, mild anemia, disproportionately low MCV, and absence of iron deficiency suggest thalassemia trait, a condition of little or no consequence. Because other types of thalassemia present earlier, they do not present at a late age. The second is acquired sideroblastic anemia. It's primarily a disease of older adults. A heterogeneous group of disorders marked by iron deposits in the mitochondria of normoblasts. All patients should receive a trial of pyridoxine, which is B6, 200 milligram, 3 times daily, but few respond. As the pyridoxine works as a cofactor in the heme synthesis, but few respond. The next slide, please. Ineffective erythropoiesis. Myelodysplastic syndromes are group of stem cell disorders characterized by disordered hematopoiesis. So it is disordered hematopoiesis. The bone marrow is usually hypercellular, but the blood counts are low because many developing cells die before maturing. This leads to anemia, leukopenia, or thrombocytopenia. Mainly, it is a disease of older adults. It's common in people over 60 years. Cytogenetic abnormalities, in which genetic changes in marrow cells are common and help classify and predict the prognosis. For example, the 5q syndrome There is a deletion of the long arm of chromosome 5, typically causes macrocytic anemia with normal or high platelets, often respond to lenalidomide. The Guglielmo syndrome, also known as erythroleukemia, a subtype of myelodysplastic syndrome with normal proliferation of immature erythroid and myeloid cells, which may progress to acute leukemia. So, in myelodysplastic syndrome, clonal stem cell disorder in older adults leads to ineffective blood cell formation, cytopenias, and chromosomal abnormalities such as the 5q or D. Guglielmo syndromes. The next slide. Hemolytic anemias. The autoimmune hemolytic anemia and microangiopathic hemolytic anemias. So the autoimmune hemolytic anemia, it's caused by that body produces antibodies that attack its own RBCs. It is diagnosed or confirmed by the positive Coombs test, the direct antiglobulin test, which detects the antibodies or complement on RBC surfaces. In older adults, often secondary to another condition, like non-Hodgkin lymphoma, chronic lymphocytic leukemia, collagen vascular diseases like lupus, and also some drugs. It is treated with corticosteroids, firstly to suppress the immune destruction or splenectomy, to remove the main site where antibody-coated RBCs are destroyed. The most effective when the antibodies are immunoglobulin G type, the warm autoimmune hemolytic anemia. The microangiopathic hemolytic anemia, it is caused by mechanical destruction of the RBCs as they pass through the damaged or narrowed small vessels. The blood smear shows schistocytes or fragmented RBCs, can occur secondary to DIC or thrombotic thrombocytopenic purpura, in which the microthrombi formed in small vessels cause RBCs fragmentation and hemolysis. The next slide, please. So, older people, vitamin B12, folate, and homocysteine. Older people are more likely than younger people to have low levels of B12 and folate. Of apparently healthy people, more than 70 or more, 10% of them have B12 deficiency and 5 to 10% have low folate. So in older adult patients with low normal B12 less than 350 picogram per mil, check methyl malonic acid levels, as I mentioned earlier, to exclude metabolically active B12 deficiency. Severe B12 deficiency and possibly mildly low levels can result in cognitive impairment and significant neurological deficits. So the main neurological manifestations of B12 deficiency are peripheral neuropathy, also subacute combined degeneration of the spinal cord, which is degeneration of the dorsal column, cognitive and psychiatric changes as well, which is called megaloblastic madness, in addition to optic neuropathy, which manifests as visual disturbances or loss. There is no evidence of link between B12 and dementia. Nevertheless, aggressive replacement of B12 and folate is warranted in patients with dementia. B12, folate, and homocysteine, to be continued. Low levels of B12 or folate is accompanied by high homocysteine, which may be linked to coronary artery disease. Homocysteine levels can be reduced with 400 microgram folate acid. folate acid once or twice daily. Regarding the vitamin B12 replacement, particularly if methylmalonic acid level is elevated, consider for patients with low normal B12 levels and macrocytosis with or without anemia. In addition to neurological changes, 1 milligram per day oral B12 is generally sufficient for patients with low normal B12. However, parenteral replacement for B12 for less than 100 picogram per ml. The effects of, just a second. So let's go for the effects of aging on platelets and coagulation. The platelet counts do not change with age. Concentrations of many coagulation enzymes increase with age, including factor 7, factor 8, and fibrinogen. Studies of sanitarians suggest that aging leads to increased hypercoagulability. Bleeding diathesis. It is not uncommon in older people, for example, unexplained bruises, repeated nosebleeds, GI blood loss, excessive blood loss during surgery, or following tooth extraction. Patients should have a screening platelet count and coagulation study, and platelet aggregation test may also be worthwhile. The next slide. Thrombocytopenia. Platelet count, thrombocytopenia is platelet count less than 150,000 per ml. This is considered significant, but bleeding usually occurs at much lower levels. So treatment depends on the cause. Decrease platelet production, irrespective of platelet count. Consider platelet transfusion if blood loss is significant. When increased peripheral destruction, usually drug-induced or secondary to autoimmune disease, so treat primary disorder, order trial of steroids if no cause is found. In isolated thrombocytopenia, exclude myelodysplastic syndrome. Also consider DIC and TTP. Disseminated intravascular coagulation and thrombotic thrombocytopenic purpura. Platelet function disorders, thrombopathies. It is uncommon but can cause significant bleeding in older people on aspirin therapy, sometimes requiring platelet transfusion. Von Willebrand disease as one of the thrombopathies or platelet function disorders. It is either hereditary or acquired. The hereditary can present initially in older people. The acquired type, disease of older people, commonly associated with monoclonal gammopathies, lymphomas, or myeloma. Desmopressin acetate may be used when treatment is necessary. If adverse effects are intolerable, try factor 8 concentrate that has high dose of von Willebrand factor. Clotting factor deficiencies. The most common acquired inhibitor to factor 8. This is the most common clotting factor deficiency in older adults. The onset is often sudden. Titers to anti-factor 8 antibodies can be very high and presents with bleeding into joints and muscles. Besides factor replacement, prednisolone or cyclophosphamide may be needed. Deficiency of vitamin K dependent clotting factors. This tends to occur in older people with major illnesses. Consider inappropriate warfarin use, of course, and readily treat with vitamin K. The excessive bleeding and liver disease. Excessive bleeding and liver disease. Consider liver disease in all patients who present with excessive bleeding. So prothrombin time is prolonged even in mild liver disease. Liver disease reduces all clotting factors except factor 8, results in lack of clearance of fibrin degradation products, and can affect platelet function. Liver disease associated with DIC. The treatment of bleeding diathesis in liver disease is fresh frozen plasma. Now let's move on to the chronic myeloproliferative disorders. The Philadelphia chromosome negative chronic myeloproliferative disorders occur primarily in older adults, like polycythemia vera, essential thrombocytopenia, and idiopathic myelofibrosis. The essential thrombocytopenia and polycythemia vera have a long natural history with the low incidence of leukemia transformation. In more than 90% of polycythemia vera patients, JAK2V671F mutation is present and is an effective screening tool. So the management of polycythemia vera. Risk stratification, in which patients are classified as low or high risk based on age and history of thrombosis to guide therapy intensity. Phlebotomy is the first line treatment in which blood is removed to keep hematocrit less than 45%, reducing blood thickness and clot risk. Low dose aspirin prevents blood clots by reducing platelet aggregation, and cytoreductive therapy used if the patient has a very high red cell mass, frequent need for phlebotomy, or high risk features. It suppresses MORO production. The hydroxyurea is the preferred cytoreductive drug, safely lowers blood cell counts and reduces thrombosis risk. So the management of essential thrombocytopenia, observation for asymptomatic or low-risk patients with platelet count less than 1,500 times 10. Hydroxyurea plus low-dose aspirin for high-risk patients. Now let's summarize what we have been discussing today. The reserve capacity of hematopoiesis diminishes with advancing age. Anemia is the most common age-related hematologic abnormality. It should be evaluated in the same way as in younger adults. In older adults, the most common causes of iron deficiency or iron-deficient erythropoiesis are anemia of chronic disease and anemia associated with inflammation. Vitamin B12 deficiency and low folate are common in apparently healthy people aging 70 or more and can be clinically important. Patients with bleeding diathesis should have a screening platelet count and coagulation study. A platelet aggregation test may also be worthwhile. A platelet count less than 150,000 is significant. Clotting factor deficiencies in older adults are usually acquired and are caused by circulating clotting factor inhibitors. Acquired sideroblastic anemia, myelodysplastic syndrome, and Philadelphia chromosome negative myeloproliferative disorders occur primarily in older people. Now let's move on to the first case. So a 75-year-old man comes to the office for a routine examination. He feels well. He is on hemodialysis for chronic kidney disease. History also includes long-term type 2 diabetes, peripheral vascular disease, and coronary artery disease. Medications include insulin, metoprolol, cevimeline, and calcitriol. Examinations are remarkable. Laboratory results show blood urea nitrogen of 20 milligram per deciliter. Creatinine is 6.5 milligram per deciliter. Sodium 140, potassium 4.4, and hemoglobin is 10 gram per deciliter. Which of the following is the most appropriate next step? So, is it begin epotine alpha with a target hemoglobin concentration of 13 to 14 milligram per deciliter? Begin epotine alpha with target hemoglobin concentration of 11 to 12 milligram per deciliter. Begin epotine alpha if hemoglobin concentration falls below 9. Begin epotine alpha if symptoms develop. What is the correct answer?
B. Begin epotine with target hemoglobin concentration of 11 to 12 milligram per deciliter.
Yes. Yes, this is the correct answer.
Thank you.
You go to the next slide. Yes, the target in patients with chronic kidney disease and anemia is the target hemoglobin concentration is 11 to 12 milligram per deciliter. The second case is an 89-year-old man presents to you complaining of generalized weakness. General physical examination and neurologic examination are normal. He lives with his wife in a rural community, is independent in activities of daily living and instrumental activities of daily living, and rarely drives. He has avoided medical care for most of his life. He is on no medications other than calcium, vitamin D, and aspirin, 81 milligram per deciliter. The laboratory tests hemoglobin is 11.9 gram per deciliter. Hematocrit is 35%. Mean corpuscular volume 102. Serum B12 is 200 picogram per ml, low normal. Methyl malonic acid is 300 nanogram per ml, increased. Homocysteine is 18 microgram millimole per liter, increased. And RBC folate is normal, and ferritin is 250 nanogram per ml. So what is the best next step? To prescribe oral vitamin B12 1000 microgram per day, administer B12 1000 microgram intramuscularly weekly for 8 weeks, followed by 1000 microgram intramuscularly monthly, or administer a 3-part Schilling test. Recommend upper and lower endoscopy to exclude pernicious anemia and bacterial overgrowth syndrome. What do you think the correct answer?
A. Prescribe oral vitamin B12 1000 microgram per day.
Yes, excellent. This is the correct answer, actually. So the patient is prescribed 1000 microgram orally. It is an oral B12 supplement of 1000 microgram because he has a macrocytic anemia, but no neurological symptoms. Also, the methyl malonic acid is elevated, or MMA. The third case is a 72-year-old woman referred for evaluation of erythrocytosis. She reports no fever, chills, sweats, pruritus, visual or auditory disturbance, headache, or dyspnea. 2 episodes of dizziness a few months ago resolved after several minutes. She is of Ashkenazi Jewish background, but there is no family history of hematologic disease. She smoked 1 pack per day for 25 years, but quit 20 years ago. On physical examination, she appears plethoric, but she is in no acute distress. Temperature is 36.2. Blood pressure is 166 over 98. Pulse is 91 beat per minute. Respiratory rate is 14 breaths per minute. The spleen is identifiable by percussion and just palpable at the costal margin. Laboratory studies 1 year ago showed hemoglobin of 16.4 gram per deciliter. Erythrocyte count was 5 by times 106 microliter. Leukocyte count 10,000. Last month hemoglobin was 17. Current laboratory test results show hemoglobin 18, leukocyte count 13,000, platelet count 454,000, erythropoietin level less than 2, which is low, serum iron 30 microgram per deciliter, iron binding capacity 324 microgram per deciliter, and oxygen saturation on room air 94%. Which of the following is true of this patient? She is likely to die in 5 years from fibrosis. She is likely to have prolonged survival with therapeutic phlebotomy. She is likely to have a major thrombotic complication such as stroke or Budd-Chiari syndrome. She is likely to die in 5 years from acute leukemia. What do you think is the correct answer?
B, she is likely to have prolonged survival with therapeutic phlebotomy.
Yes, this is the
She
correct
has
answer again.
polycythemia vera.
Yeah, this is polycythemia vera, and the correct answer is B. So this was the presentation of today on some of the hematologic diseases and disorders that are common in elderly. Thank you very much for your attention.
Thank you, Dr. Mawahib, for this great and informative presentation. Next, we will hear from Dr. Eptihal Nour, who will discuss professionalism and hierarchy in U.S. medical training. It is an essential topic for anyone preparing for U.S. residency or clinical rotation. So, Dr. Eptihal, please take the floor. And I will share the screen from my own.
Hello everybody. Good afternoon, Dr. Nadir. Good afternoon, everyone. Thank you for the opportunity to be here with you today. I would share it, please, Doctor, because I have it online. If I will try to, please, if you don't mind. Okay. Do you see my screen?
You will share the screen, or I can share?
I want to share it because I have it's online,
Okay.
so it's like yeah, I just give it the PDF for the record. So
Okay.
thank you, Doctor.
Go ahead.
Thank you so much. So let's start here. So today I'm gonna talk to you about professionalism and hierarchy in U.S. residency training or in medical training as general, your guide to U.S. residency rules and communication. I'm Dr. Eptihal Nour. Okay, so why this matters? Why focus on professionalism? Core competency. Professionalism is a core competency in U.S. medical education. Different expectations for IMGs, different healthcare system, mean different expectations. Understanding U.S. norms helps prevent miscommunication. Linked to success. Strong professional behavior is closely linked to medical knowledge, clinical skills, and accountability. Okay, so the goal, establish habits early to build trust, support patient safety, and ensure your development. We're going to talk about key topics here, key professional topics, hierarchy, Chain of commands start from interns, then residents, that means senior residents, and attendants. Communication, respectful, disagreement, and assertiveness. Safety, reporting mistakes and near misses. Conduct, dress code, punctuality, and professional boundaries. Growth, peer and faculty evaluations. Chain of commands. We're gonna see the US structure. Chain of commands, your US team. Okay, intern BGY1, first year after medical school, and they are the foundation of the team. Then resident BGY2 plus, gain increasing responsibility and manage the intern team. After that, the chief resident, administrative, scheduling, and educational duties, a liaison to faculty. Attending physician, fully trained supervisor, holds ultimate responsibility for patient care. Action, know whom to escalate, is to key to safe, efficient care. Chain of commands, why it matters. Hierarchy is for structure, not silence. Clarity, clear rules prevent gaps or duplication in patient care. That's why we have hierarchy in the medical healthcare. Escalation, you know who must be informed about changes or concerns. Safety culture, modern training emphasizes open communication over rigid hierarchy. Okay, we have a tip here. As a junior, you are still a vital part of the team. Never hesitate to ask questions. Okay, then we're going to talk about the respectful disagreement and assertiveness. The safety script, how to speak up. It's expected to speak up when you have a safety concern or an unclear order. Respectful means a calm tone, factual language, and focus on the issue, not the person. So we have example here, example script, the CUS technique. So you're going to say, Dr. X, I'm concerned, the adversity, I'm concerned about the order for Mr. Y. The lab results seem inconsistent. I'm uncomfortable proceeding without clarification because I believe this could pose a safety risk to the patient. Could we please review the plan together? The mindset here, asking questions, is not a sign of disrespect. It's a way to support team safety and ensure the best patient care. Errors are system problems. We're going to talk about the reporting mistakes and near misses. Mistakes happen. The focus is on the systems and improvement, not blame. Near misses, event that could have caused harm but did not. Example, mislabeled lab. Reporting prevent future damage. Culture of safety. US programs require opportunities for residents to report errors and unsafe conditions. The action, you need to know your institution reporting process. So every system, every hospital, they have their own system. You need to be familiar with that, be honest, and focus on what needs fixing. Professional conduct, the three pillars, dress code, punctuality, and boundaries. Okay, the professional appearance, clean attire, visible ID badge, no excessive perfumes or clones. Punctuality. Punctuality means reliability. Be on time for rounds, clinic, and procedures. If delayed, communicate in advance and ensure coverage. So the goal here is like patient safety and smoothness of the healthcare. Professional boundaries. Interactions with patients must remain strictly professional. Protect patient confidentiality, especially in social media. The feedback loop evaluations, peer and faculty evaluations. You will both give and receive evaluations from peers. That's expected during your training, from peers, juniors, and faculty. Key professionalism attributes, dependability, respect, and communication. Behavior matters. Completing your evaluations on time and attending required conferences and essential professional behaviors. The tip here, view feedback as a growth opportunity. When you evaluate others, be constructive and fair. Your action plan, what I can do. Putting it all together, your action plan. So the structure, know your team, senior resident, attending, and the chain of command. Clarity. Ask questions early and often. Better to clarify than assume. Safety. If something seems off, like you feel something wrong, or if there is any mistakes with order or plan, raise it respectfully. Integrity. Report errors, near misses, to help build a safer system. Presence. Maintain a professional demeanor, timely, reliable, and respectful. Growth. Be open to feedback and perform evaluations consciously. Okay, navigating cultural norms. IMG focus. Common challenge and tip for IMGs. Hierarchy. Be aware that if your prior system had a steeper hierarchy, US training is generally flatter in terms of patient safety. So US now, in US, they are transitioning to a more flat hierarchy. And I will let you know that steep hierarchy, that means it has many layers of management, leading to slower decision-making and communication, but clear lines of authority. In contrast, a flat hierarchy has a few or no management layers, enabling faster, more collaborative decision-making and greater employee autonomy, but can have challenges with career progression and clear leadership. Okay, communication style. Observe how your team communicates. So, do they communicate by email, paging, in person? Match the tone and formality. With everything, with every law, you have to check your like system, your institute, and do the same. Speak up. US culture values input from all levels. Your expertise matters. Time. Arriving early is generally preferred over arriving precisely on time. Mentorship. Identify a senior resident or attending you trust to ask, what is expected here? Okay, so the summary, your professional success. Professionalism plus hierarchy equals stronger training. Defined rules, as we said, intern, resident, and attending, but communication flows up and down. So they work like a team. For behaviors, respectful assertiveness, error reporting, boundary keeping, and punctuality. Engage early. As a new resident, engage early, observe actively, and never hesitate to ask. Okay, we're gonna have like small discussions here. Are there specific scenarios you anticipate that might challenge you? Speaking up or reporting an error. Let's discuss real-world scenarios. Okay, we can work together on strategies to address this challenge. I have examples here. Challenge number 1, navigating the flat hierarchy. If your prior system was rigorous, how will you cautiously remember to speak up respectfully when you disagree with a senior resident or attending. The strategies here. Okay. So first, actionable tip, shift your mindset. View speaking up not as a disobedience, but as a patient safety check. Your role is to protect the patient, which supersedes hierarchy. So the whole team is like, the priority here is like patient safety. But we have to do that with respect, of course. Use a script. Employ a structured communication tool, such as the CUS technique we talked about, concerns uncomfortable safety, or the AIDET framework, acknowledge, introduce, duration, explanation, thank you, when raising concerns. Focus on the data frame. The disagreement is about objective facts or evidence. Example, I saw the potassium is 6, or based on the recent study in JAMA, I'm concerned about, avoid making it personal. Ask a question. Instead of directly contradicting, ask a clarifying question that prompts a review. Can you help me understand the rationale for this order, given the patient's renal function? The error report. Here's the other scenario we're going to talk about. Imagine you discovered a near miss caused by a system flaw, like confusing labeling. What are the first 3 steps you will take to report it at your new institution? Immediate patient safety check, if applicable. First, ensure no patient was actually harmed. So as we said, the patient safety is number 1, and that the error cannot be immediately repeated. Example, secure or remove the confusingly labeled item. Inform the team supervisor. Immediately notify your senior resident or the attending physician on service about the near miss, emphasizing the potential for harm and the nature of the system flaw. Use the institutional reporting system. Access the institutional officials, often confidential, online reporting systems, example, safety event, medication error, or near miss report. These ensure the event is logged and initiate the system-wide review process. Rationale, US hospitals use these reports to track trends and fix system issues, not to punish individuals. Okay, the feedback gap. This is the third scenario. You could face the challenge, you receive a negative feedback that you feel is unfair. How do you respond professionally in the moment? And what is your plan for follow-up? Okay, we're going to talk about the professional response. The moment, listen and acknowledge. Do not become defensive or interrupt. Say, thank you for sharing that perspective. I want to understand this better. Avoid immediate emotional responses. Set up a follow-up to reflect on the time. After you thank your senior or the attending about bringing the error, then request a formal follow-up meeting. You could say, could we meet briefly tomorrow during a non-clinical period so I can ask you some specific questions about how I can improve this behavior. For the follow-up, seek specifics. Focus on the behavior and the impact. Ask, can you give me specific examples of when I was perceived as, and you state the unprofessional behavior or the error? What specific action would you prefer I take next? And you ask for advice to help you be better. Of course, we always learning as a physician. and then document. Keep a private record of the feedback, your understanding, and the actions you plan to take. Okay, and then this helps demonstrate your commitment to growth if issue arise again. Thank you for listening. Wishing you growth and success in your residency training ahead. Thank you so
Thank you,
much.
Dr. Eptihal, for highlight those important aspects of professionalism. So our last topic will be guiding through using Google Keep for quick clinical note, presenting by Dr. Mohammed Makkawi. But unfortunately, he apologized due to health issue. We wish him speedy recovery. Now, I would like to take a moment to thank all our presenter for this excellent work and preparation, and also thanks all participants for your attention and active engagement today. Now, I'd like to invite Dr. Nadir to share today's announcement and project update.
Okay, thank you,
you so
Dr.
much.
Huzaifa. Welcome.
You're welcome.
Thank you, Dr. Nadir. We appreciate your time and support as always. Thank you, everybody, for listening.
Thank you so much. Thank you both for great presentations, and thank you, Dr. Huzaifa. And before I jump to the announcement and the updates, just want to share with you there are different ways of doing the to-do list in your day-to-day activity. You are currently either in the US or outside the US. I hope when you join residency, hopefully soon, what you need to do is you need to be organized, and to-do list is one of the things that you need as a tool when you start your rounds, when you want to study for the exams or the test and the board exam, when you graduate from the residency. So I think it's very important tool, and there are different ways to do it. So I'm going to show you. There are simple ones, and then there are more complicated ones. So the simplest one is you take your paper, you write your list. Let's say you accepted to a residency. Then one of the things or tasks that you will be assigned to, you will see your patients early in the morning before you round with the attending about your patients. So you will have a printout list of your patients. So you need to do things about each patient. Let's say patient number 1, I need to follow up on the labs. Patient number 2, I want to follow up on the x-ray. Whatever you need to do, so you can carry on your paper and tick all the activities or tasks that you finished, and those are not done, you can just circle or make a square around them. So this is how most of people will do their to-do list. Very simple example, for example, when you want to go and do shopping, you want to go to get something to make or prepare at home to cook. So you have a recipe, you need to get these items of the recipe. So when you go to the store, the supermarket, you will have a to-do list where you want to buy this, for example, milk, eggs, bread, and so on. So you tick everything that. So the main idea is to remember everything when you are in the store. Instead of you buy stuff, you come home, oh, I forgot to get the eggs, for example. So it's a tool that will help you make sure you complete all the tasks or every task possible. And this is very important to you guys when you are seeing your patients, because when you round with the attending, you will have better understanding what's going on, what's the whole plan, and what steps are you finishing, what are steps you want to do in the future. So if a patient comes with, let's say, cough problems, and you're thinking of congestive heart failure, you want to get an X-ray or an echo or whatever, then you put that on the list to do, and next day you want to follow, or by the end of the day you want to follow what's the results about the echo or about the X-ray, what it show, and this will help you complete your plan. So the next step, you're gonna ask cardiology to see the patient, or you want to put the patient on Lasix or whatever you think is going on. So this is just the background about to-do list, why you need a tool to help you complete tasks in your day-to-day at home or at work. So Google has come up with a way to do that. So we have, there is a Google Task Manager, and there is what we were planning to present today about Google Keep, or sometimes you can use it for clinical notes. So when you see the patient, you want to make sure you take a good history. So you want to make sure you follow up with family history, social history, and so on. So when you keep your notes, you want to complete this with history you obtained from the patient. Nowadays, you will have your computer with you, like in a cart in some of institutions. So you will do that while you are rounding, or one of your team will do that when you are rounding. But nevertheless, it's one of the tools. It's called Google Keep. So I'm gonna see if we can so basically it will create the list for you, or you want to create a checkbox list. And I'm gonna show some of the images. So this, I'm gonna share the screen with you guys. So basically it's gonna be something like that. You will have a list, and then here you can categorize the list, and you can add what you want to do in a format that's similar to this one. So you need to, let's say, a list of shopping idea, or a list of patient, a list of to-do list, and so on. So this is a web page that you can use to, so how to use Google Keep to create unlimited task list. Basically, you will go over how to do this. So simply, you have a list you want to create, and then you, in that list, you want to add task, and you add note about whatever task that you want to complete, for instance, and it will be shown as a checkbox for each task on your list. You can make as many lists as you want to, and as you finish a task, you just click on the box. It will highlight, or it will de-highlight, or change the text color so that it shows you it's done. And or sometimes it's just a check mark, like a check. That means the box is done, or this task is done. And the one with the empty box, those are the tasks that are not done. There are different apps that you can use on your phone to do the same. So you can, in iPhone or Android, sometimes it comes with a to-do list app, or you can download some of the apps yourself. And this is just the same idea. You put a list of what you want to do and check as you go along, as you complete these tasks. This is just basically what we want you to know. And hopefully some of you are doing that right now. I'm going to stop for a moment. I want your input. Any one of you used any of these tools or used a simple form of just a paper and a pen to do your whatever activity or list that in a daily basis or in your work? Please jump in and share. Thank you.
Assalamu alaikum. Hello.
Assalamu alaikum, Dr. Ali.
Thank you, Dr. Nader, for sharing this with us. Yes, I want to share my input. I used the Notes app in the iPhone, usually in my to-do list or even in the shopping list. Yes, and it has this facility which allows you to add boxes in front of each items, and then you check it if you're done with it. So yes, iPhone has this Notes app that help you to do your list. Thank you.
Thank you so much, Dr. Arid, for sharing your input with us. Yes, it's very useful for you guys. And Dr. Einas as well mentioned that she's using that as well. So it's a very useful tool for you guys if you want to try it, if you didn't use it in the past, and just familiarize yourself with any of these tools. You can download some of the free apps and do the same. And hopefully it will help you in your career. Thank you. So the next item in the agenda and the announcement, I want to share with you that tomorrow there is an interview session or webinar, and it's in the app if you want more information. So number 4, match interview webinar. It will be tomorrow at 11 a.m. New York time, Eastern time, and they have some information about that. So you can go and register for tomorrow if you have some time. And this will be, I think, some advice, some tips, maybe mock interview. I don't know how long it will take, but this is what I found. So for those who planning to do some interviews or apply to programs, if you have time, maybe you can join this interview sessions. And to update you also, this is a match interview for tomorrow. We started doing the paperwork for the Geriatric Research Fellowship, so we are waiting for them to approve it. If it's approved, and then we will have the Geriatric under the Combined Research Foundation, and hopefully we can get the ball rolling, and will help you in the future and build some programs that can be funded and so on. Last item is the update from you guys. So anyone would like to update us with their active or activity or research projects? What are you doing, guys, and so on? Just let me know. Update
Hello,
us.
Dr. Nader.
Hello, Dr. Einas, please go ahead.
So I think 2 weeks ago, alhamdulillah, our poster got accepted in the 23rd Annual Saudi Neonatology Society Conference for poster presentation. And I'd like to show you from the beginning, how things started, the idea from the very beginning until the poster presentation, inshallah. Can
Inshallah,
you share
go
my
ahead.
screen?
Congratulations. Yes, go ahead, please.
Okay. طيب. Is my screen visible?
No.
Okay, let me check again. Is it visible now?
Yes, it has a keyboard, and yes.
Yes, okay. So starting with the idea, so our topic and our systematic review was called Do Probiotics or Symbiotics Affect Diarrhea in Children with Severe Acute Malnutrition? This was a systematic review, and we've registered it in Prospero. The idea started when I was working in Al Banjadid Hospital in Sudan, okay, as a house officer. Okay, so we had a lot of patients who had severe acute malnutrition, and I really wanted to find if there was like a possible alternative management, because over there we use the ready-to-use therapeutic food and other management for severe acute malnutrition. I wanted to see if we could use probiotics. And so this was where the idea came from. Forming the team, I made a Google form and I sent it at the TGRF, on the WhatsApp group. Okay, and I wanted to form a team. From those who had like a previous experience with the systematic review and meta-analysis. We had in the team we included people who had a previous experience with with the meta-analysis, with the screening, and so on. Because this was my second project, but it was done simultaneously with another project. So it was a bit easier, but at the same time, like I did not reach, I did not complete the full tasks of the systematic review in the other project. So I wanted to like learn more and lead this project. Alhamdulillah, yani, I had a really good team. Alhamdulillah, we did a good job. When it came to completing the tasks and doing the tasks, I think the most important thing was actually setting realistic expectations. Because a lot of people, like whether they were studying for the USMLEs or they were having like other jobs, so I needed to like set realistic expectations, which also meant that I should be flexible with my team, which is alhamdulillah, and it's something that I learned it. Alhamdulillah. So another thing was that I think the project reached a plateau because after we finished like doing the systematic review and so on, we did not proceed further with the meta-analysis. Honestly, we just registered it as a systematic review. So I reached out to Dr. Nadir, and he suggested that we should submit it as a conference abstract. Alhamdulillah, that was a very good advice, because in that conference, while presenting my poster, I had like a lot of ideas through engaging with experts in the field, and they were giving me their opinion about the topic, what they think, like how the meta-analysis should be further done. So it was a really good experience. Okay, so submitting. We had, okay, so this one submitting. So I was looking also for conferences. I wanted a conference that is local, so I wouldn't have a problem with the visa and the traveling and so on. So and me and Dr. Saida, together we were looking for local conferences. Alhamdulillah, we found two conferences, one in Qatar and the other one was in Saudi Arabia, which is the one that I presented at. So I wanted the full experience. So this is the invitation that was sent to me by the Saudi Neonatology Society. So it was first a national conference, but then they invited like international speakers, really good speakers. We had Dr. Joseph New from the University of Florida. He came in and gave like an excellent lecture about microbiome and probiotics, which is something that I'm really interested in, and it's related to my topic and presentation. So this was in the when submitting it, they sent us this layout, okay, or what is it called, a form for the presentation, and then we had to like fill it up. Yes, and this is the e-poster. in the conference. It was like a big screen, like all the posters were presented in big screens. It was yes, this one. This one was our poster presentation. The conference topics, they were different, and it was all all the speakers were in the field of neonatology, and they were like the best speakers, and one of like the best speakers, yes, in Saudi Arabia, the best doctors over there in the field of neonatology. They spoke about intestinal obstruction, about a microbiome, about eclampsy. These are very like here we have Dr. Saif Assaf, okay, and then we have here, this is Professor Joseph Nour from the University of Florida that I've spoken about. Okay, who's speaking about the dogma and tradition regarding microbiome and probiotics. It was a really informative lecture. Okay, this is also a picture that I took together with Professor Joseph Nour, and this was with Dr. Amira Wushi. Okay, she's a neonatologist, a Sudanese neonatologist, and the best thing that happened actually was knowing her in this conference. Like she started introducing me to everyone in the field as her daughter. Like, and the only thing that connected me to her was just our Sudanese blood. She didn't know me beforehand. She didn't know anything about me. We just connected over there in the conference, and she is a neonatologist over here in Saudi Arabia. So it was a really nice experience, and it was a really humbling experience, in my opinion. Yes, and this was when presenting the poster. Alhamdulillah, and I was honored on stage by Dr. Ibrahim Al-Hifzi, who was who was the head of the conference. But the pictures on stage, it was not shared yet with the organizing committee. Like, inshallah, like once they share it, I'm going to share with you. Okay, and this is the certificate. Okay, so as a research participant, we did not win, but I won actually something bigger than that. I won connection. I won um, further perspective about our research, like where should we be heading with our research. So it was a really nice experience, and I do um, um, wish that if anyone had an opportunity to poster present or present their poster, present their work at any conference, I think they should choose um, being on site rather than virtual, because the connection over there, like on site, you get like the real experience of things. So you should not be discouraged if you cannot like travel abroad due to visa issues, due to visa restrictions, and so on. You can choose local and national conferences, national opportunities. It's okay, yani. Inshallah, yani, next time, inshallah, we're gonna do it like or we're gonna present and attend like more international conferences, inshallah.
Thank you so much. And again, congratulations, Dr. Einas, and your team. You did a great job. And thank you for sharing your tips and reflection on the conference itself, meeting people. So I agree with you as far as presenting virtual versus presenting in person. Definitely, there are a lot of things that you can gain meeting people, and in the US, for example, you can also make connections for future research projects, or even knowing programs if you are interested in certain specialty. So in the past, we have some of the fellows who presented at different conferences here and made some good connections. And I think it helps them with these connections. So thank you for sharing, Dr. Einas. Any comments
You're
or
welcome.
any from?
And thank you for having me.
Thanks. Thanks. Anybody else?
I have a question, Dr. Nadir, if you will,
Yes.
please. Thank you.
Sure.
So, as you are an expert in the field, I'm interested to learn more about geriatric. So, do you recommend any websites like or a book or anything that I can get to learn more about it, please? Thank you.
So thank you for the question, and thanks for sharing your interest. So where are you located now, Dr. Eptihal?
In Virginia.
Virginia, okay. So
Yes.
for you, I think the best option is to log into the AMTA program. It's called in the past. Now I think they changed their name to, I'm going to share the screen just to let you know what I'm doing.
Okay.
So if you go to search for AMDA, the American Medical Director Association, it's now they call it post-acute and long-term care. This one. This is the easiest one. You can join them as a member. You can mention you are a student because it's still you didn't finish getting into residency. So the level when you are resident, then you go to fellowship or fellows and so on. So you didn't reach that. So it's, I think it's free. This is one option, and usually they have chapters. So this is national, and then there are some local. Maybe in Virginia, you might have, if you go to, maybe you can just Virginia, you can search.
Actually, it's Virginia.
They have a chapter or something, yeah. So if you have that, that's one option. You can connect with the local in Virginia, see if you want to get in contact and make connection and see. Usually they have the national conference. It will be in March next year, 2026, and we can also submit some abstract or some paperwork there, or you can attend the meeting. I think it's going to be in California. That's one option. The other option is American Society, American AGS, the American Geriatric Society. Also, they have chapters, and you can join the national. I think it was for $60 to become a member or something. So this, as far as connection, there are other societies or groups that you can join as well. So this is as far as how to go about. To learn more about the geriatric itself, this fellowship, we have a list of, let's see again, a list of topics that we discussed. So if you go to files, you can search for certain things. I was searching for the hematology this morning. So you can see what topic you want to, and usually it's a GRS. This is the teaching slides, like the one they presented today. I think there are a couple, 20 something slides. So you can go one by one. If you want to, you can go back to the previous topics in the previous meetings, and you can also search about what topic you want to COPD in all the adults, something like that. Usually it's the first topic about the geriatrics. So you can see the slides, or if you want to learn more about the topic, some of the presenters updated this and presented it, so you can do that. So we touch base on most of the topics most common, and then sometimes they call it geriatric syndromes. Like in pediatric, there are some syndromes specific to that group. We have in geriatric some common problems. We call it geriatric syndromes. So if you cover most of these, you will be familiar with the topics or the main problems that older adults will face. These are some of the resources that you may access wherever you have time. You can get to the slides, you can get to the old videos from this program. I think you can find more information from the websites that I mentioned. So if you go to AGS, they will have more information, and the Medical Director Association also, they have like guidelines. They have more specific topics addressed, so they may have some additional materials. So there are a lot of things that you will have available if you have time to go over. Thank you for the question.
Thank you so much. I appreciate your help. Thank you so much. And I just want to add, I attended like a clinical research boot camp in a medical school in my city. I just like contacting them, and I said like I'm an IMG, I'm interested. They welcomed me to go. So they talked about a lot of like apps and AI in medical field. When I checked the telegeriatric apps, most of what they talked about is like in your app. So thank you so much, you and all fellow doctors here. Like I felt like it's like treasure box, honestly. So thank you so much. And anyone need any help with anything, you're just gonna find it in the app. Just keep checking the old slides, presentations, and sessions. Thank you, Doctor.
Thank you so much, Dr. Eptihal, for also sharing this point. Thank you.
Yeah, sure. Thank you. You're so welcome.
Any other updates, any other comments, any other input, suggestions, or any questions?
You're mute, Dr. Nazir.
I just want to thank you. I want to update you with two research projects. One of them is a manuscript that was submitted about oral health education knowledge and so on. It's systematic review. And Dr. Dalia and her team also submitted an abstract about sleep science and or abstract to the sleep science meeting conference, and that was about melatonin use on sleep disturbance in patients with dementia, specifically for Alzheimer's dementia. So we wish you all the best, both teams.
Thank you. That's my team, actually. Yeah, hopefully gonna get accepted.
Oh, sure.
Yeah.
And I wish you and your team all the best. That's good.
Thank you so much.
You're welcome. So if there is no more questions, again, I'd like to thank you all, Dr. Huzaifa and your team, all the presenters, all those who attended today's meeting. Thank you for coming over. And those who will watch the recording in the future, I'd like to thank you in advance. And if you have questions or any suggestions, comments, please reach out, and you can email me, you can send a text or call or WhatsApp. we'll help as much as we can. Thank you so much, and I wish you all the best. Have a wonderful day or night. Assalamu alaikum. See you next week.
Alaikum assalam.
Wa alaikum assalam.
Yeah.
Thank you.